So I will now give the floor to Franz Nolle, but he was not able to attend, so I must apologize. We have Dr. Fieke Koopman.
On behalf of Professeur Nolle, and nous connaissons ici le professeur Nolle qui vient souvent dans nos congrès présenter l'organisation.
So he's often here to present the organization of health care in the Netherlands because it's a structure that is quite specific. They have a center that is in charge of the entire country. And so thank you.
Well, thank you very much for your introduction. As just said, unfortunately, Professor Nolet was not able to be here today, so I will take over his presentation. Oh, this was too quick. Can I go one back, maybe? Yes. You can see him here on the photo on the first slide, and I think it's good to notice that actually he is the founder of the Post-Polio Expert Center. My name is Fieke Koopman. I'm working as a rehabilitation physician for around 8 years right now. In my presentation, I will tell you something about the Post-Polio Expert Center in the Netherlands. I will also tell something more about the multidisciplinary one-day PPS program that we have. And I will tell something very short about 2 research lines, namely orthotics and aerobic exercise. I would like to start by giving some numbers, some figures, and I think they're actually quite the same patterns as can be seen in other European countries. In 1957, the routine vaccination started in the Netherlands, so the big epidemics were before that year. But what you can also see in this slide is that after 15/7, there were some small epidemics in the Netherlands as well, some small outbreaks, I need to say. And that was actually in villages in the Netherlands where patients or people did not want vaccinations, mostly because of religious reasons. But what we should also notice is that, or what we also see is that the number of patients that did not contract polio in the Netherlands is increasing. So I think that nowadays almost half of the patients, or around half of the patients we see contracted polio in the Netherlands in the past, and half of the patient population is much younger and contracted polio in other parts of the world. Yes. Then over here you can see a map of the Netherlands with the Post-Polio Center in Amsterdam. As you can see, it's quite centrally located, so that's good. And also it's good to realize that the Netherlands is around 13 times smaller than France. So for a lot of patients with polio, it's quite doable to visit the Post-Polio Center. The distances are not very big. Actually, we see around 100 new patients with polio each year. And when a patient is new for us, then we always start by doing a medical intake by one of our rehabilitation physicians. We will start with an interview, of course, just asking about post-polio complaints, the acute polio phase, the stable polio phase, but of course also how patients are doing right now, what are current complaints. Then we do a physical examination, and then we decide on what kind of additional tests need to be done. And actually what we do very often is imaging of the muscles by means of MRI scans or CT scans. And actually that helps us a lot in knowing what the quality of the muscles is. It gives us much more information than what we get from the physical examination alone. Then we do also gait analysis for patients who have mobility problems. And sometimes when we have doubts about the diagnosis of post-polio syndrome, we refer the patients to one of our neurologists. Then a little bit more information on the multidisciplinary polio day that we organize. 4 weeks in advance of this day, patients receive a questionnaire. And in that questionnaire, they fill in a 2-day activity list. So for 2 days, they fill in every 30 minutes what kind of activities they are doing and if it comes with complaints of fatigue or pain. So actually it helps the team members to understand a little bit better how activities relate to PPS complaints. Then we also have a questionnaire on coping styles. And what we also find very important is that patients in advance of this day really think of what their questions are to the team, what kind of topics they want to discuss. So it helps the team to stay focused during the day, and it helps the patient to prepare for this day. I listed some frequent themes that were addressed during these days. I don't know if you recognize things which you can see here, but I think the main general question is how to deal with post-polio syndrome, how to deal with the decline. But sometimes patients also have a little bit more specific questions, like can I do muscle strengthening exercises, or how to stay fit, or how to stay mobile, or advices on home adjustments. And what I find quite noticeable was that there were not so many questions on emotional factors. While we do know that a lot of patients have acceptance problems or are anxious about their future. So therefore we always have a social worker in our team. And then the PPS day itself, it's always on a Monday and it starts in the morning with a pre-meeting of the team. The rehabilitation physician already has seen the patient before, so he or she transfers the most important information to the team. And then the patient is going to see a physiotherapist, an occupational therapist, a medical social worker, and a rehabilitation physician, all in line. Then for the patient there is a break, and then we have a team meeting with the patient, so the whole team is together, and we will give a summary of our main findings, our main insights, and the advices we want to give. And sometimes when it's necessary that a treatment plan is made, or when the patients need more consultations, then we discuss, do you want to come back for that to Amsterdam, or should we refer you back home? Also, we make a report which we send to the patients afterwards, and we always do an evaluation by telephone around 6 weeks later. And I would like to share some experiences of patients and of ourselves with this day. First of all, I have to say, patients always say it's very intensive. They're all tired after all the consultations with the different team members. But actually, this day is highly appreciated. Many times we hear patients say, this was the first time that there was a whole team of therapists with experience in my disease who gave me so many new insights. So actually, therefore, I think it's also quite an efficient way of doing healthcare, because it's just in one day with a whole team, different insights, short lines, so it will sometimes really gives a good start. And for us as a team, it really enforces interdisciplinary cooperation. We have short lines during that day, and I think it's kind of a team building. So this was some topics on how we do clinical care in the expert center. But of course, as we work in an academic hospital, we also do research and education. And I want to shortly highlight 2 teams, namely orthotics and aerobic exercise. First of all, orthotics. We've heard it before this morning. Mobility problems are frequent in patients with polio, that's clear. There are complaints of instability and falling, high energy cost of walking and standing, sometimes complaints of pain in the lower back, in the hips, but also in the upper arms due to use of crutches. And sometimes there's low walking speed, of course. Here you see a slide of different orthoses. There's a large variety. You can see orthopedic shoes, you can see ankle foot orthoses, you can see the knee ankle foot orthoses, the higher devices, and you can also see that there's the conventional leather and steel devices and the carbon composite orthoses. I think we're working with this material for already around 20 years, so we're quite used to it. So we do studies, of course. It started in around 2000 when we did a study on the effects of carbon composite knee ankle foot orthoses as compared to the older leather and steel devices. But we also do studies on use and usability of CAFOs. We know that when we provide a patient with a knee ankle foot orthosis, not everybody will wear it. So we want to understand better why that is. And then some current studies and future perspectives are on the different knee joints. It was also addressed this morning. And in the future, we want to gain more insight in the newest knee joints, like the C-brace, which we call the auto-adaptive knee joints. We also do a lot of studies on ankle foot orthoses. Again, use and usability is a main topic, but also stiffness optimization of ankle foot orthoses. We know that for each patient there's an optimal stiffness. If it's too flexible, it doesn't work, but if it's too stiff, it also doesn't work. So it's quite important that the stiffness matches the individual needs. So future studies are really focusing on making simulation models and human-in-the-loop optimization to better predict or to better see what kind of stiffness suits the individual patient. Then I would like to say a little bit on how we organize our orthotic care in our daily clinical practice. We really work by means of a systematic approach. In 2012, we developed a guideline. Unfortunately, it's only in Dutch, but it's being updated, so hopefully it will be in English available as well. But this really gives us a very... It really gives us a very good systematic approach to work with. And what we also do is with almost all patients who receive an orthosis, we do a 3D gait analysis. So it helps us better to make decisions on what kind of orthosis we should prescribe. What we do is, because we do the instrumented gait analysis before we prescribe the orthosis and afterwards with the orthosis, we can also evaluate what we did. We evaluate our care, and that helps us improving this care. And of course, the scientific research where I just talked about. And then finally, but definitely a very important one to remember, is the multidisciplinary approach. You can't give this kind of care when you do not have a team of experts. So you need an orthotist who is experienced, you need a physiotherapist, you need somebody who can do the 3D gait analysis. You need a rehabilitation physician who can manage the multidisciplinary team. And then I will jump on to another topic, aerobic exercise. In the past, patients with post-polio syndrome were told avoid intensive exercise because it can cause overuse, muscle weakness. But actually there's a growing number of trials on aerobic exercise in this population that says that it's quite safe. And there is some evidence that aerobic exercise has positive effects. But these studies all have very small numbers, different types of exercise interventions were being investigated, and sometimes there is also a large dropout. So therefore, in 2008, already some time ago, we wanted to study one of our exercise trainings. What we did, we had a home-based individual training program on a cycloergometer. And patients came to the center for supervised group training once a week. And we gave a high intensity, high volume training. That means starting with around 50% heart rate reserve and increasing within 4 months to 70% heart rate reserve. And then with a frequency of three times a week. And actually the duration of these exercise bouts were also quite long, starting with 30 minutes and extending to 40 minutes. So we studied this intervention in a randomized clinical trial in different centers in the Netherlands, and then we had our results. And these were the results. There were no effects on fatigue, there were no effects on self-reported physical activity, and there was no effect on aerobic capacity. So actually that was very disappointing. And we wanted to understand better why this did not work. So we did a study on that. And we saw that actually the attendance rate was quite high, so people were doing their training. But what we also saw is that none of the participants trained within the target heart rate range, more than 75% of the designated time. So they were either training on too high intensities or too low intensities. So we said we need a more individualized approach. Patients with PPS are so different from each other. We need individualization. So that's why we developed the BFIT training guideline. We formed a multidisciplinary expert group consisting of rehabilitation physicians and patients and movement scientists and physiotherapists. And we planned some group sessions in where we shared scientific knowledge and results from earlier studies that we did and expert opinion. And then there was a training guide. And this training guide consists of a part for the therapist and a part for the patient. And it is different, of course, from the intervention that we studied earlier. And I think the most important difference is that it is a polarized training. And what does it mean? It means that actually it's a training on low intensity. Patients are training for 2 times in the week with a low intensity, and then there is only one high intensity session. But at high intensity sessions, there are very short bouts. So high intensity rest. You can see it in this figure. Again, it's a home-based individual training with supervision of a physiotherapist. There are some individual face-to-face sessions to check how it's going and some telephone sessions. We made this training guide, we translated it in the English language, and it's available on the internet. So if you scan the QR code, you can read everything about it. And we also made a very short video on YouTube, which you can also find if you scan the other QR code. And then, of course, we wanted to know if this program was working. So first of all, we did a pilot study. We included 31 individuals with 15 different slowly progressive muscle diseases, and 11 of these patients had post-polio syndrome. The completion rate was 84%. And first of all, we asked patients and therapists, what do you think of this intervention? And the most important thing that patients told us, I really feel fitter. And if we asked, can you also mention a downside, then they say, sometimes it's a little bit boring. And then we asked the therapists, and they said, this is a very well-grounded, it gives us a very well-grounded guidance. And a downside they mentioned is that the time investment for initiating the program is quite large. We did some outcome measures on important markers for aerobic capacity. It was a post-intervention study, so no randomized study, and actually what you can see is that on the main parameters of physical fitness of aerobic capacity, you can see that this program is effective. It makes patients more effective. Of course, we need to study this intervention in a randomized control trial, and that's what we did. We started this study, I think, around 4 years ago right now, and we're finalizing this study, and hopefully in the end of this year we can present the results of this study as well. And on my last slide, in the meantime, we're also working on international collaboration. We want to evaluate feasibility and effectiveness of the BFIT on a larger international scale. So we received some funds from the Post-Polio Health International to implement this program in the United States for patients with post-polio. We received a fund from Muscular Dystrophy Canada to implement this program for patients with muscular dystrophy. And we also received a fund from AFM Teleton to implement this training in some centers in France and targeting at different slowly progressive neuromuscular diseases, including patients with post-polio syndrome. And that was the last slide of my presentation. Thank you very much for your attention. Also on behalf, of course, of all my colleagues.
Thank you very much. Thank you very much. It is always very interesting, your experience in Netherlands. Thank you very much. Est-ce qu'il y a quelques questions?
Do you have questions from the audience? Yes, we do.
Shall I?
Well, I can say it in English if you know it, so no problem. So my question is, did you experience high-intensity interval training, or does it make no sense in the case of poliomyelitis? You know, high-intensity interval training, it's very high, and then a rest or slower trainings.
Yeah, well, actually, I think that a lot of patients with post-polio can do high-intensity training, but the problem in this study was that we did not really had a good way or good methods to determine what is high, what is low. We did it based on a heart rate reserve, and actually we know that for healthy people, people with normal muscles, this works quite okay. It's also not perfect. But I think the conclusion was that this method does not work for this population. So we need other methods to determine the adequate training intensity. So what we now do is we do exercise tests with breath-by-breath gas analysis, and that's much easier, much better to see on what training intensities patients should train.
And maybe another question about nutrition. Did you take care of the protein intake?
Yeah.
You know, if it could be beneficial, for example, whey protein, or is it beneficial or not in the case of poliomyelitis or not?
Yeah, it's a very
especially
interesting.
if you get older, you know that protein metabolism is weaker, is slower. You have to intake more proteins, even if you have no polio. But in the case of training, maybe you should have an extra intake. So did you check
Well, actually,
that?
in this intervention, we did not pay special attention to it. Actually, we advise all our patients to make sure that they have sufficient protein intake, because, of course, that is very important. But this is a topic that we are really interested in doing future studies. Together with frequently asked questions from post-polio patients that they're gaining weight and they find it very difficult to lose weight. And in the meantime, we know that it affects mobility problems. So, diet is an important topic that we are starting to focus on right now. But in this study, not so much, not so specific.
Thank you.
J'ai bien entendu que vous...
So I've heard that you are presenting this program for the PPS patients, but do you also target this at patients that are seeing a degenerative sequelae with aging?
Devoted only for post-polio syndrome or for all the patients being polio with all their different difficulties.
No, we are indeed a rehabilitation center in an academic hospital. So within our outpatient clinic of rehabilitation, we see all kinds of diseases. But one of our major topics is patients with neuromuscular disease. And within the team of neuromuscular disease, the post-polio group is the biggest group that we are seeing right now. Yeah.
Thank you very much. I'm sorry, I think we have to stop. We are really late. Thank you very much.